The setting I chose to interview with was an outpatient OT pelvic floor therapist based in New York. I chose this because I've always been very drawn to women's health, and I feel like it's a very important conversation and area to engage with and explore, especially in today's context. So I really wanted to do that and kind of get an idea of where OT fits in there. So, when I was asking her how she defines OT to her clients, she did say that while she does say that OT broadly is a field that does whatever it takes to get you back to your daily life, your meaningful occupations, and what it looks like to be you. She said because her field is so niche and so specialized, she does often just explain what she does in her daily work. And even with that, there's a lot of variability. But because it's so specialized, she does tend to just focus on her branch. She did, however, mention that when it comes to PT and OT in this field in particular look almost identical. They have a lot of overlap with their goals and their interventions and kind of what that looks like with a client. So she said the best way that she differentiates PT and OT in this setting is understanding what lens you're initially looking through. So if it's more biomechanical, and kind of what's physically going on your body, that's going to lean a little bit more PT versus, okay, so this is what's happening in your body. How is that affecting your habits, roles, routines, function at home? That kind of lens, that's going to lead more OT. But she did say best practitioners in both fields cover it all. She uses a biopsychosocial model in her practice, and there is no way around it. She leans very heavily into biomechanics here in her daily practices, evals, interventions, treatments, all of that. But she said it's also impossible to work in this field and not deal with mental health, kind of both stems from potentially working with patients who do have sexual trauma or sexual abuse, but also working with women who are experiencing pelvic pain that is so often overlooked by other doctors and practitioners that it may have taken them a while to even get to this field. So she said it is impossible to address the client in just one way or the other. It is integrated into her work, the biopsychosocial model. So her clients are pretty wide range, anywhere from 20s to late 70s. They're most often coming with either pelvic pain, maybe bladder or bowel issues, and then they could also either be pregnant or postpartum. So she often gets a lot of referrals from OBGYNs, urologists, GIs, and also word of mouth is very big in this field. Somebody whose friend received treatment, you're more likely to receive treatment or seek to receive treatment yourself. So for an initial eval, she kind of breaks it up into almost 2 sessions so it can be more comprehensive. First day is going to be comprised of a subjective assessment where she'll spend anywhere upwards of 30 minutes just talking with the patient, getting their history, their pelvic health routines, and just getting their firsthand account of what's going on inside their body and how that's affecting them in their day-to-day life. And then she'll kind of follow that up with a pelvic floor examination or assessment that's both internal and externally looking to see how the muscles are contracting, moving, things like that, and then internally where she is manually inserting a finger into either the vaginal or anal canal to kind of ascertain how strong muscle function is, if the muscle is contracting the way it should be, and also if there's any pain associated with that insertion. To be noted, all of her clients do have vaginal canals. So that's kind of day one, and then day two is going to be more looking at the rest of the body. So at core strength and stability, at hips, at functional mobility, at breath work, to kind of get that full body picture. Now, she did mention that people can and do decline a pelvic examination, which she never pushes for. If they change their mind down the line, she'll accommodate it then, but otherwise, if somebody declines, she doesn't push it. She's like, you can still do what you have to do without it. Does make it a little bit more challenging, but spending more time on core breath work, functional ability, you can kind of draw those correlations and connections to the pelvic floor. So she never pushes if somebody says no, and they're always welcome to say no. So in terms of goals that she's working towards, biggest one that she sees more often is going to be centered around pain. Next, again, would be like incontinence with any bowel bladder issues. Return to exercise is a big goal for a lot of her patients, as well as just sexual functioning, both with pain and then in other areas as well. So as she's moving through treatment and intervention, there's kind of two branches. There's like a movement and then a habit-based. So movement encompasses anything like exercising. So, strengthening your core, looking at functional mobility, training those kinds of movement, training breath work. And breath work itself is kind of twofold. One, it helps coordinate pelvic floor functioning in that movement, focused with the breath. And then it's also mentally stress reduction, kind of calming the nervous system as well. And then looking at habit-based, that's more kind of retraining people's day-to-day. So with a lot of times with like bowel bladder issues, maybe going to the bathroom at the same time every day, different things like that. There's a lot of overlap and it is very dependent on the client, but those are kind of the biggest methods of intervention, I guess you could say. And then speaking of the breath work in terms of the mental health, as I mentioned earlier, mental health is a huge part of this field. It is one of the best things she was saying about the field because it is such an, personal and intimate conversations that you're having every day, really building those connections. They're very strong connections. They're very important connections. There's not a lot of space outside in society to have these kinds of conversations. So being able to provide that space is very rewarding. But then on the flip side, that can also sometimes be the hardest part of the job, that mental toll of hearing what these patients have had to go through with in the past with abusers, even just with doctors not believing them, things like that. So she said the biggest thing she can do, or she does in that way, is just giving them the space, letting them fully be able to express themselves in a safe environment, and validating what they're going through, that their pain is real, that their experiences are real. She said the mind-body connection to pelvic floor functioning and health specifically is so strong, and there's no way to just address one of those at a time. They are very, very much interlinked and coordinated. In terms of determining discharge, she does often use, once again, those subjective assessments. If a person feels like they have reached their goals, or even if they're not quite there yet, maybe they're close, they feel like they have the tools to continue working towards that on their own, or to be able to deal with any setbacks, that is considered mission accomplished. That's considered a good thing. Sometimes if there's maybe a little bit of disconnect between what a person's feeling and maybe what she's seeing, she'll bridge those kinds of conversations and explain kind of objectively what she's noticing and explaining what she would like to see before moving to the point of discharge. So it's an open conversation, but it is very subjective based normally. Otherwise, in terms of culture, she said the biggest cultural difference that she sees in a lot of patients is in terms of religion or maybe stigma, how comfortable they are talking about sex. And then she just kind of adjusts and matches them where they are, if they're very comfortable talking about sex versus if they're not, kind of adjusting that and just seeing how they want to have those discussions and kind of letting them take the lead there. So sometimes those kinds of patients, it takes more education time as part of their intervention, so they understand what's going on in their body, but just taking it at their level. Otherwise, she said in terms of field work or getting prepped for this field, it is a lot of CEUs because there is such a big biomechanical focus. So she said if anybody's interested, as I am, doing anything you can for a pelvic floor rotation or finding a mentor in the field and starting those CEUs, the earlier the better, is kind of gonna prep you for this very niche and very specific work. But overall, I really enjoyed hearing from her and hearing kind of what her day to day tends to look like. I very much enjoyed hearing about the mental health aspect, and it did kind of solidify my interest in working with women in a field to validate, empower, strengthen, and get them back to their lives in ways that's so often overlooked by society. Um, so, yeah,